Can you guys hear me okay?
Sure can.
Yeah? Okay. I just wanted to thank Eric so much. Thanks for pronouncing that word correctly, minimally. That's really good. I told him before the talk that you can use that for a Scrabble word in case you forget some Scrabble, words that you need to use. But I really sincerely want to thank Eric for supporting our program. He has done phenomenally. I mean, he is an inspiration to even myself and Al, actually, in terms of exercising. He's just done an awesome job, and he's been such a supporter of this program and of all the patients. I oftentimes see patients in the office, and I said, I have the perfect person for you to talk to, Eric Washlager, because he is phenomenal, and he even goes, I must say, even up to the floor and sees patients post-operatively and counsels them as well. Right after surgery, already saying, come on, get up and walk. You can walk already. So I just want to put a plug. Eric's been awesome. Also, Laura has been very supportive in the marketing department, and Stacy and Kelly have been awesome. This is actually Al and I's first baby, this as well as our practice. And, before we moved out here from Los Angeles, that was one of the things that we wanted to create as a bariatric program. And actually, before this hospital even opened, we came around walking in hard hats, and we wanted to make sure that we had floor-mounted toilets, so eventually we would become a center of excellence. So definitely, this is something that we've been striving for, and hopefully within the next 5 to 6 months, we'll get there. And we're so happy that all of you are here attending today. This is definitely a treat every year to have all of the successes of our patients. So I'm going to just give a little talk about updates in bariatric surgery. Some topics I'm going to talk about. It's not going to be too long. It's not like our seminar, so don't worry. I'm going to talk about bariatric surgery operations, the two that we perform here, and actually the indications of surgery. Are the current bariatric surgical outcomes and current research, as well as our outcomes here at our program here at Cedar Park Regional. And then looking to a new frontier in robotic bariatric surgery, as Eric alluded to in his opening for me. So weight loss long term. So Dr. Bell talked about body image, and even starting off as a small child, everybody wants to lose weight and get thinner. You get to a point where if your body mass index, at least from the research, if your body mass index gets too high, it's very difficult to lose weight through diet and exercise alone. And so this research is actually from the 90s, so it's a little bit old, obviously, but this basically highlights that if your body mass index goes above 40, what does that mean exactly? Well, it's about 100 pounds overweight. When you get to that point, it's just very, very difficult to lose the weight to get to a normal body mass index with just diet and exercise. And so surgery definitely has a play there. And this study shows, you can kind of see on this graph, that if your BMI, the solid line there, is surgical patients, so the BMI of those patients started up higher at a BMI of 50, and actually it came down to 2 years. 2 years is where we reach kind of our maximum weight loss, and then we kind of plateau at that point. But over time, over the next 7 years, they maintained their weight loss. But the other arm, which is diet and exercise, they ended up over time regaining that weight. So definitely surgery can be used as a tool to help you to get to a healthy weight. And just like Dr. Bell had mentioned, we don't think of a success from bariatric surgery as just weight loss. We think of success as getting rid of your diabetes, being able to get rid of your medications, get rid of your blood pressure medications, being able to walk with your kids, being able to engage with them. Those are all the successes from the surgery that we perform. It's not just a number. So what are the indications for weight loss surgery? Basically, these are from the 1990s. 1991, NIH put out a statement, and it's basically a body mass index over 40 or a body mass index over 35 with a medical problem, like I mentioned, diabetes, high blood pressure, sleep apnea. This is one of the surgeries that we perform. So when the models come out, we'll say what type of surgery they had. This is the Roux-en-Y gastric bypass. I have a little video that we'll show right after this to kind of go over the anatomy. It's actually one of the gold standard procedures. It's been performed for the last over 50 years. And it's known to actually work in two ways. One, by decreasing your appetite, but also anatomically by decreasing the amount you can eat and also not allowing you to absorb as much. So that's why it's called restrictive and malabsorptive. You know, as we were doing these operations, we actually realized as surgeons, you know, the patients who had type 2 diabetes, their blood sugars already started to improve within about a week to 2 weeks after surgery, after a gastric bypass. And as a surgical society, we're like, why is this happening? So there is so much research out there being put into the physiological mechanism of how the gastric bypass works, and it's actually by bypassing a critical area of your intestine that causes your ability to see insulin again. Type 2 diabetics can't see that insulin, and so with having a gastric bypass, it allows that to happen, and blood sugars normalize within days after surgery. It's not because of the weight loss, it's because of the actual operation. And these findings were so profound for our society, because we don't cure medical, you know, as a surgeon, we rarely are able to cure medical conditions. But our society actually added, instead of being the Association for Bariatric Surgeons, they have there the Association for Metabolic and Bariatric Surgeons, because now we can actually make a change in metabolic diseases. The average weight loss for a gastric bypass patient is about 75% of their excess body weight. So if you're about 100 pounds overweight, on average you would lose about 75 pounds with a gastric bypass. This is a video. This shows an open approach, and it's basically making a big incision. Now we obviously do it with laparoscopic instruments, making small incisions. And if we can magically look in the body and see what we're doing, we basically create a small stomach pouch at the top there. And so this is your new small stomach. And so we detach it from the rest of the stomach and bring a loop of intestine to it, which bypasses a portion of the intestines. So it's a kind of fancy procedure. It's actually one of the most complicated laparoscopic procedures we perform as surgeons, as general surgeons. And so you basically bring up the other loop of intestine, and now you have a whole new sort of configuration. So when Eric was saying, yeah, they're just gonna move around my organs and stuff, this is what we're doing right there. Kind of fancy. You know, and oftentimes I see patients post-op and they're like, oh, this is actually better than my gallbladder surgery. I mean, it's literally 5 or 6 small incisions. You're up within 4 hours after surgery. You're getting liquids the first day post-op. So you feel like nothing really happened, but we did a lot in your belly at that time. So that's the new anatomy right there. We also do what's called the sleeve gastrectomy, and this is just a restrictive procedure, so we just make a small stomach pouch. This also decreases appetite, and there's a hormone that's produced in the stomach called ghrelin, which we talk about in seminars, which increases your appetite. So if you didn't have any lunch when you came in and you're starving, your ghrelin levels are sky high. And so with this surgery, as well as the gastric bypass, ghrelin levels drop dramatically, and that's why these patients have a lot less hunger. For the sleeve gastrectomy, the average weight loss is a little bit lower than the bypass. It's about 65%, so 65 pounds out of 100 if you're 100 pounds overweight. And this is the sleeve. So basically we just detach a portion of the stomach pouch. So, and then just make a smaller stomach. So interestingly, you know, a lot of times in the media, they talk about bariatric surgery. We've had a bad rap with bariatric surgery, saying, oh my gosh, it's too drastic. It's scary. You know, you don't want to do that. You want to do diet and exercise. You don't even want to approach bariatric surgery. Well, this study shows volume of patients of 6,000 patients in Canada, where half of them had bariatric surgery and half of them were just doing weight loss with diet and exercise. And what it showed was the patients who had bariatric surgery within a 5-year time period after surgery actually had a 9 times lower risk of dying compared to patients who didn't have the surgery and stayed at their weight. So bariatric surgery is saving lives. I mean, I think people think it's so drastic and it's so worrisome, and it's the mortality rate is high. Actually, the mortality rate of doing a laparoscopic gastric bypass is the same as taking out a gallbladder. So we've definitely come a long way from, decades ago. So I wanted to pull some current research. This is from actually JAMA. If you go and try and look in the library or something and you want a magazine that has a lot of different research on bariatric surgery and weight loss, actually the September 19th issue of JAMA had a whole magazine devoted to weight loss and bariatric surgery and medical weight loss. And this is the complex thing that goes on. If you can see in that center picture right there, controlling weight gain and weight loss. So there's so many hormones involved. There's so many things that are signaling throughout your body to make you either gain or lose weight. And so surgery, we try to affect some of those pathways, but definitely, it's very complicated, obviously. Some research on bariatric surgery. This one actually is entitled Health Benefits of Gastric Bypass Surgery After 6 Years. And actually in this study, it had over 1,100 patients, and they had 3 different groups. They had a group that had a gastric bypass. They had the group that actually wanted to have a gastric bypass, but they didn't have a gastric bypass. And then they had another group that just didn't seek to have surgery. They were, trying to diet. And so in the 3 groups, it showed that weight loss maintenance was actually the best in the gastric bypass group. And actually diabetes remission was 62% in the gastric bypass group. It was 8% in the group that wanted to have bariatric surgery. So typically those are your dieters. And then in the group that did not want to have surgery, their diabetes remission was 6%. So definitely, medical problems improve with gastric bypass surgery and sleeve gastrectomy. Sleeve gastrectomy also reverses diabetes, but it's over a time period. So instead of it being immediate, typically it starts to happen a few months after the surgery once you're losing weight. This also shows that the cost benefit for bariatric surgery for the patient is good over the long term, because obviously when you think about it, if your medical problems go away, you don't have to pay for all those prescriptions that you had to in the past. So this study just kind of shows that after 6 years, you notice a huge benefit in terms of the cost for medical care, because you don't have to get hospitalized for your diabetic issues, and you don't have to take prescription medications. This is our Cedar Park Regional Bariatric Program. Actually, this needs to be updated, so sorry, Diana, you're not in this one. And Danny should be switched out for Lindsay, so we'll need to get a new one. But this was Laylee, who Eric mentioned is the one on the far right there, who he cornered one day asking for surgery. And the approach that we take to bariatric surgery is one that's called multidisciplinary. And the reason why is we're the surgeons, sure, we give you the tool, but it's everybody else that also does the work to help you succeed. Every one of these patients who comes up here will tell you it's not just the surgery that got them there, it's everything else. So you have to do changes in your diet, you have to do changes in exercise and increase your exercise to be successful. Al and I both are surgeons, so we'd like to say, sure, we did it, we were the reason why you lost the weight. But honestly, to tell you the truth, we're probably about 50%, 50 to 60%. All the rest is up to you and everybody around you to make sure, you live a good lifestyle, that you eat well and you exercise. It's not a quick fix by any means. So this sort of slide elicits that it's not just us, it's everybody else in this program, and we're so happy to have this program here to provide all our patients with really, really awesome care. These are some of our statistics of our patients, and this has been compiled. We keep a database on all our patients to see how they're doing. And our diabetes improvement is 100%. Our high blood pressure improvement is 87.5%. Our hyperlipidemia resolution is 86%. Sleep apnea resolution was 100%. Actually, I had a referral from a pulmonologist who sent a patient who had sleep apnea and referred the patient for a gastric bypass, and then a couple months later said, "Why did I refer you? Now I have to take you off a CPAP, so I'm not going to see you anymore." So unfortunately, they can lose some patients, but it's for the better of the patient. Improvement in joint pain is 96%. So definitely our statistics show that the operation not only helps with weight loss, as you'll see as the models go down the runway, but it also helps with a lot of medical issues. This is our excess body weight loss, and on average, our patients actually do very well. They lose about 44% of their weight at 2 to 4 months post-op, 56% at 5 to 7 months, 65% at 1 year, and awesomely, they lose about 98% at 2 years post-op, which is a huge achievement because the national average is actually 75%, 65% for the sleeve and 75% for the bypass. And so we really think having this comprehensive approach has helped us succeed to this standard. Our complication rates are there. We don't like to talk about complications, but the only complications that we've had early on were bleeding at 4%. Average is 0 to 5%. We have had no leaks. We've had no pulmonary embolisms, which is blood clots to the lungs, or blood clots in your legs is a DVT. And we have had 0 deaths. So got to knock on some wood here. I always do that just to keep that going. So definitely our complication rates are really, really good. So just talking a little bit about robotic surgery, just to let you guys know, we performed the first bariatric surgery using the robot, completely using the robot here in Austin and actually here in Central Texas. And that's a big deal because we have our neighboring hospital down the road who's also doing robotics, and it seems like everybody else is now starting to do robotic bariatric surgery after we started it a few years ago. So we actually started using the robot since we got it here in 2010 and started using it on bariatric surgery with a lot of good outcomes. For those of you who don't know about robotic surgery, it's not that we basically start the surgery, leave the robot there, and check in about 2 hours later after having some coffee. We actually are doing some work. So we're sitting at a console that you can see right there on that picture, right next to you on the operating room table. And looking into a viewer, we look at a 3D image of your anatomy on the inside. It's way better than your naked eye could even see. So we can see really fine detail in this viewer and control the tips of the instruments on the inside of your body. So, it's by far the best technology in terms of doing any sort of laparoscopic procedure. And so we have that technology here. We have the most advanced robot here at Cedar Park Regional. And, we're very proud to be able to use such awesome technology. And there's a lot of research now starting on robotic bariatric surgery, and it actually shows that you have decreased morbidities after having, for example, a gastric bypass where you do that connection between the stomach and the intestine. That's called the gastrojejunostomy. It's shown that actually we have decreased leaks from that area by using the robot. And actually over time, using the robot decreases your cost. So you hear that, Eric, over there? Yeah. Using the robot over time decreases cost because you don't have to use as much staplers and other equipment that that you would use doing it laparoscopic, and also with decreased complication rates, you'll obviously have less hospital stays and issues with complications, also decreasing costs. And so I just wanted to show you a little video. It's actually a video of one of our cases, so hopefully the patients out here, this is blinded, but this is showing you the technology of the robot. This is where I'm actually tying a knot by doing my connection between the stomach and the stomach pouch, and those are the robotic instruments right there. So very fluid. You know, I'm just using my fingertips to control the instrument. Those are both robotically controlled right there to create the anastomosis between the stomach up there and the intestine down below. So you can see all those 3 instruments, the 2 that were controlling the knot, as well as that other one, are all controlled by the robot. And the view is phenomenal. And so I think that's the wave of the future. So we're doing the wave of the future surgery here at Cedar Park. Definitely we're proud to be here, and we're proud of the success we've had with this program. So thank you very much.